Usually when we talk about treating a medical condition, there's this expectation of synergy. Like the intensity of the treatment should generally match the durability of the body part you're treating.
Right, yeah. It feels intuitive. A resilient problem gets resilient treatment.
Exactly. I mean, if you have a stubborn callus on your heel, you scrub it with a tough pumice stone. The physics of it just makes sense.
But for sure.
But then you step into the world of severe mucosal inflammation, and suddenly that entire logic it's flipped upside down. It's like being handed an industrial pressure washer and being told to, clean a 200-year-old paper-thin antique silk lampshade.
Yeah, it is the absolute definition of a medical tightrope walk.
Well, welcome to this custom-tailored deep dive. We have a highly specific and honestly highly critical mission for you today. We are unpacking the incredibly strict safety protocols for applying clobetasol propionate.
Which is a huge topic.
It really is. This is a super high potency topical steroid, and the protocol involves putting it directly onto the body's most delicate, thin mucosal tissues. We're specifically targeting conditions like anogenital lichen sclerosis and oral lichen planus.
And this is vital information for you to understand if you're navigating these treatments. Because, frankly, the margin for error is razor thin.
Definitely. So to get to the bottom of this, we've pulled together clinical guidelines from the British Association of Dermatologists, the NHS, the Mayo Clinic, Bayview Pharmacy, plus a whole slew of pharmacological studies and clinical trials.
It's quite the stack of sources.
Right. And the core contradiction we're exploring today is this. How do you safely use one of the most powerful anti-inflammatory medications available on the most fragile, paper-thin tissues in the human body without causing irreversible damage?
It's an incredible paradox. You're dealing with a medication that carries explicit bold print warnings on its label saying, do not use on the face, groin, or armpits.
Right, the bold print warnings are terrifying.
They are. And yet, for these specific autoimmune conditions, the groin and the mouth are exactly where it needs to go.
So if we look at the pharmacology of clobetasol propionate, specifically at this 0.05% concentration, it's categorized as a super high potency steroid.
Yep, highest class.
To me, using this on thin mucosal skin sounds like using a controlled demolition charge just to open a locked door. Why are we bringing this level of firepower to tissue that the general guidelines basically scream at you to protect?
Well, what's fascinating here is the why. Because of the underlying nature of the diseases themselves. Conditions like lichen sclerosis and oral lichen planus aren't just your run-of-the-mill surface rashes.
Right, they're much deeper than that.
Exactly. They involve severe chronic T-cell mediated inflammation. Your T-cells are essentially your immune system's frontline foot soldiers.
Okay.
But in these conditions, those foot soldiers have gone rogue. They're launching a full-scale, relentless attack on your body's own outermost borders.
Wow. So the tissue is essentially on fire from the inside out, meaning a standard over-the-counter hydrocortisone cream isn't even going to make a dent.
It wouldn't even touch it. I mean, you need a mechanism that can forcibly shut down that rogue immune response.
Yeah.
Clobetasol works by penetrating the cells and inducing the production of inhibitory proteins.
These are the lipocortins, right?
Yes, lipocortins.
And what do these lipocortins actually do once they're activated?
They act like a systemic roadblock. Lipocortins inhibit a specific acid called arachidonic acid.
Okay, arachidonic acid.
Right. And by blocking that acid, you completely shut down the biosynthesis of prostaglandins and leukotrienes.
Wait, so you're basically cutting the communication lines? Like, if prostaglandins are the chemical messengers screaming at the immune system to keep the inflammation going?
The clobetasol silences the messengers.
Wow.
Precisely. It neutralizes the inflammatory mediators right at the source. The sheer severity of the mucosal inflammation absolutely necessitates this level of biochemical power.
Because anything less just wouldn't work.
Exactly. But because we're using that demolition charge, the strict physical application protocols are, well, they're the only things preventing severe collateral damage to the tissue.
Okay, let's unpack this. If we're dealing with a medication this potent, the actual physical application is where I get incredibly cautious.
As you should.
Because if I have a severe, painful inflammation spreading across the sensitive area, my immediate instinct, and I think the instinct of anyone who has ever put aloe vera on a terrible sunburn, is just to smear a thick layer everywhere.
Oh, absolutely. It's human nature.
Right. Just cover the whole area to create a protective barrier.
Which is the fastest way to cause permanent harm in this scenario. You have to fight that smear instinct entirely.
Really?
Yes. The medical consensus requires geographical precision.
Meaning the medicine targets the exact footprint of the lesion and absolutely nowhere else.
Exactly. The medication must go only on the affected lesions. If you smear it everywhere, you are exposing healthy, already thin mucosal tissue to a drug that inherently suppresses cell growth.
Oh. And that leads to the skin thinning, right?
Yes, severe skin thinning, known as atrophy. And on top of that, it drastically increases the amount of the drug seeping into your bloodstream.
But how do you actually measure that in practice? I mean, if I'm applying this to anogenital lichen sclerosis, how do I know I'm not overdoing it?
Well, the clinical guidelines utilize a very specific, standardized metric. It's called the fingertip unit, or FTU.
The fingertip unit.
Right. 1 FTU is the exact amount of ointment squeezed from a standard tube that reaches from the tip of an adult index finger down to the first crease.
That seems almost remarkably small for a severe condition.
It is. It equates to exactly zero 0.5 grams. The NHS guidelines visually describe it as a garden pea-sized amount.
Just a pea.
Just a pea. That single half-gram pea-sized amount is clinically proven to be enough to treat the entire affected inner vulvar or anal area.
That level of precision makes sense for the skin, but treating oral lichen planus seems like a logistical nightmare.
Oh, it's incredibly difficult.
Because the inside of the mouth is a wet environment, it's constantly moving, you're constantly generating saliva. How do you keep a targeted half-gram of steroid exactly where it needs to be?
It's a massive physical challenge. You can't just rub a standard ointment on a wet inner cheek. I mean, it'll wash away in seconds.
Right.
First, you have to physically dry the lesion as much as possible before application, usually with gauze.
Wait, if my mouth is full of active, painful ulcers, pressing dry gauze into them sounds excruciating.
It is.
How is a patient supposed to physically manage that?
It is incredibly uncomfortable, but it's a necessary evil for adhesion. The medicine simply cannot bind to a layer of saliva.
Oh, okay.
Once the area is dry, the clobetasol is often mixed with a mucoadhesive paste. Orabase is a really common one, in a strict 1-to-1 ratio.
Okay, so half steroid, half paste.
Exactly. This paste interacts with the remaining moisture to form a sticky, protective film over the lesion.
So it's essentially creating a medicinal, waterproof plaster inside the mouth.
That's a perfect way to visualize it. For application, patients are advised to use a soft bristle brush or a cotton swab to paint it precisely onto the lesions.
So you don't use your finger.
Right, because you want to avoid touching the surrounding healthy gums. And for really difficult areas, dentists will sometimes even create custom-fit mouth guards.
Oh, wow. Like a retainer?
Kind of. You
Okay.
load the steroid gel into specific pockets of the mouth guard, lock it in place, and it physically holds the medication against the targeted tissue while shielding the rest of the mouth.
That's fascinating. The engineering involved there just highlights how crucial that geographical precision is.
Absolutely.
But this brings up a massive contradiction for me. If it's this dangerous to apply a tiny amount, how can we use it long term?
Yes. The timeline issue.
Yeah, because the warning label on a standard tube of clobetasol literally screams, do not use for more than 2 consecutive weeks.
Right.
But lichen sclerosis and lichen planus are chronic, lifelong conditions. You can't just cure them in 14 days.
You've hit on the exact contradiction that terrifies most new patients. They read the insert, it explicitly conflicts with the doctor's orders, and they panic.
I would panic.
Yeah.
So how do you balance the need for long-term suppression with a drug this potent?
By utilizing a controlled descent. Because you're dealing with deeply embedded autoimmune conditions, if you stop cold turkey after 2 weeks, the suppressed inflammation just comes roaring back.
It rebounds.
Severely. So the British Association of Dermatologists mandates a strict 12-week tapering regimen for vulvar lichen sclerosis.
So a 3-month phase-out, how does the math on that work?
Well, you start by applying it once a day, every day, for the first month to gain initial control.
Okay, month 1 is daily.
Right. Month 2, you step down to alternate days, so every other day. Month 3, you step down again to just twice weekly.
And then what?
After that, the physician evaluates you for a maintenance dose, which might be just that single pea-sized amount once or twice a week, indefinitely.
It really is like landing an airplane. I mean, you can't just cut the engines completely when you're still at 10,000 feet.
That's a great analogy.
If you just stop the steroid abruptly, you enter a free fall, you trigger a severe rebound flare-up or topical steroid withdrawal. You have to glide the immune system down gradually to a safe cruising altitude.
Exactly. And if we connect this to the bigger picture, this tapering schedule isn't just about preventing a flare-up. It's about strict dosage math.
What do you mean?
The absolute red line maximum dose for clobetasol, where systemic toxicity becomes highly probable, is 50 grams per week.
50 grams a week is the danger zone.
Yes. But if you follow that taper and get down to a maintenance dose of a half gram twice a week, a single 30-gram tube should last a patient 4 to 6 months.
Oh, wow.
You end up using between 30 and 60 grams annually.
So you are staying miles below the weekly danger limit, even though you are managing a chronic condition year-round.
You are maintaining control over the disease using the absolute minimum effective dose.
Here's where it gets really interesting, though. I want to pivot to the environmental rules surrounding this drug.
The rules are very strict.
Yeah, because this is where the daily routine gets surprisingly rigid. We've established the dosage and the map of where it goes, but there's an entire physical ecosystem around the application that dictates how the drug behaves.
The environment you create on and around the mucosa absolutely dictates the absorption rate.
Let's look at what I'm calling the emollient gap.
Okay, I like that term.
For genital applications, patients use soap substitutes and emollients, basically heavy moisturizers, to protect the skin barrier. But the protocol mandates waiting exactly 30 minutes between applying the emollient and applying the clobetasol.
Yes, the 30-minute rule.
Why the strict half-hour gap?
Because of mechanical dilution. If you apply a heavy emollient and immediately apply the clobetasol on top of it, the two mix on the surface of the skin.
Oh, I see.
You are physically diluting the super high-potency steroid with a moisturizer. The concentration drops, the drug can't penetrate effectively, and you aren't getting the prescribed dose to the T cells.
Which defeats the whole purpose.
Exactly. You have to let the emollient fully absorb into the tissue, wait the 30 minutes, and then apply the steroid to a completely clear surface.
That requires some serious daily scheduling. But the environmental rule that really shocked me is the strict warning against occlusion.
Yes.
You are never supposed to cover the treated area with tight diapers, plastic pants, or non-breathable bandages unless a doctor explicitly orders it.
Occlusion is a massive danger multiplier in dermatology. When you cover treated skin with an airtight, watertight barrier, you trap ambient body heat and moisture against the tissue.
And heat and moisture fundamentally change how the skin barrier operates, right?
Dramatically. It causes the outermost layer of the skin to swell and become hyperpermeable. It stops acting like a shield and turns into a direct, open gateway to your circulatory system.
So the drug just floods in.
Right. Occlusion forces exponentially larger amounts of the steroid through the tissue and directly into your bloodstream, which bypasses the local area entirely and triggers systemic side effects.
The oral application rules are just as intense. I mean, you can't eat or drink anything for 30 to 60 minutes after applying the gel to ensure it stays in place.
Correct.
But the pharmacy protocols also include a massive all-caps warning: never swallow the medication.
Swallowing clobetasol introduces a super high-potency topical steroid directly into the highly absorptive lining of your gastrointestinal tract.
Which is definitely not where it belongs.
It is simply not formulated for internal digestion, and doing so rapidly accelerates that dangerous systemic absorption we just talked about.
And speaking of internal digestion, we have to talk about the grapefruit rule.
The classic grapefruit interaction.
I always find it fascinating when a common breakfast food derails advanced pharmacology. Patients using the oral gel are specifically warned to avoid eating grapefruit or drinking grapefruit juice.
It's a classic interaction, but incredibly crucial here. Grapefruit contains specific organic compounds that inhibit an enzyme in your liver and gut called CYP3A4.
CYP3A4. And what is its job?
That enzyme's primary job is to break down and metabolize many complex drugs, including systemic corticosteroids, so your body can safely clear them.
Okay, so if the grapefruit inhibits that enzyme.
The drug doesn't get broken down. It just continues to circulate, and the levels of clobetasol in your bloodstream can spike to toxic levels.
But wait, if we're just painting a tiny bit of gel onto a mouth ulcer, how is enough of it getting into the bloodstream for the liver enzymes to even matter?
Because mucosal tissue, particularly in the mouth, is incredibly vascular. The blood vessels are sitting right beneath the paper-thin surface.
Oh, right.
The tissue doesn't act as a barrier. It acts as a highly efficient, permeable membrane. The drug seeps straight into the local capillaries and enters systemic circulation almost immediately.
So what does this all mean? If I'm the patient managing all of this, measuring out half grams, timing my moisturizers, dodging grapefruit juice, I need to know the difference between the medicine doing its job and my body raising a red flag.
Absolutely.
Because if I have severe oral ulcers or inflamed genital tissue, everything I touch it with is going to hurt. How do you distinguish a normal reaction from a dangerous side effect?
It requires hypervigilant monitoring of your body's hidden thresholds. For example, let's look at stinging.
Okay.
When you apply clobetasol to an open mucosal lesion, it is completely normal for it to sting or burn for a few minutes.
Which makes sense. You're rubbing ointment into an open wound.
Right. But if that severe stinging or burning lasts for 1 to 2 hours after application, that crosses the threshold into abnormal.
Wow, an hour or two.
Yeah. That is a primary red flag indicating you have likely developed an allergic contact dermatitis to one of the base ingredients in the cream itself.
Not the steroid, but the cream.
Exactly. Often to preservatives like cetosterol alcohol or chlorocresol.
So your immune system is reacting to the vehicle carrying the drug. You'd need your doctor to prescribe a different formulation, like an ointment instead of a cream.
Exactly. Another massive threshold to monitor is the microbiome. Because clobetasol is a localized immunosuppressant, you are deliberately turning off the local immune response.
Which means the local police force has basically gone home, leaving the door wide open for opportunistic infections.
Precisely. Your mouth and anogenital regions are jungles of microorganisms constantly competing for resources.
Sounds chaotic.
It is. When you suppress the immune system, Candida yeast, which is naturally present in small, harmless numbers, suddenly has no natural predators. It multiplies unchecked, leading to severe oral candidiasis, or thrush.
I noticed in the clinical data that thrush is so common with oral clobetasol that many protocols dictate using prophylactic antifungal drugs right alongside the steroid from day one.
Yes, very standard.
But there was a debate in the literature about how to handle it. Some doctors suggested just using a chlorhexidine antibacterial mouthwash, while others strictly preferred actual antifungal medications. Why the split?
It comes down to practical clinical mechanics. Chlorhexidine is somewhat effective against the yeast, but it is known to frequently cause excessive salivation and oral rashes of its own.
Oh, that's not helpful.
Not at all. When you are already battling painful oral lichen planus, aggravating the mucosa further with mouthwash is completely counterproductive. Antifungals are vastly preferred because they specifically target the fungal cell walls without aggravating the surrounding tissue.
That makes total sense. Target the specific invader without collateral damage.
Exactly.
But what about when the drug bypasses the local tissue entirely? If it gets through that vascular membrane we talked about, what are the systemic red flags?
This raises an important question because the most critical systemic issue flagged across the Daily Med and Mayo Clinic data is HPA axis suppression.
The hypothalamic pituitary adrenal axis.
Yes. Your adrenal glands are responsible for producing cortisol, which is your body's natural stress hormone.
Right.
If your body absorbs too much synthetic clobetasol into the bloodstream, your brain detects those artificially high steroid levels. It assumes you have plenty of cortisol, so it tells your adrenal glands to go to sleep and stop producing it naturally.
Which sounds catastrophic if you suddenly encounter a high-stress event, like a car accident or a severe infection, and your body physically cannot produce the hormone needed to respond.
It can be life-threatening. The physical warning signs of adrenal suppression include unexplained, profound muscle weakness, severe stomach pain, rapid weight loss, and extreme fatigue.
That's terrifying.
It is. Systemic absorption can also disrupt your glucose metabolism, triggering high blood sugar. You have to watch for extreme thirst, frequent urination, or breath that smells uncharacteristically sweet and fruity.
The pharmacological data also flagged vision problems, which is, honestly, the last thing I'd associate with treating a mucosal skin condition.
I know, it seems unrelated, but if the steroid builds up systemically over time, it can alter the fluid dynamics in your eyes.
Really?
Yes, it increases intraocular pressure, which can lead to glaucoma, or it can cloud the lens, leading to cataracts. Any sudden blurry vision or seeing halos around lights requires immediate medical evaluation.
Good to know. And finally, we have to touch on the cancer monitoring protocol. Conditions like lichen sclerosis and oral lichen planus inherently carry a slightly increased risk of malignant transformation.
Yes, specifically developing into squamous cell carcinoma over time.
Which underscores exactly why this medication is so critical, right? By aggressively controlling the chronic inflammation, you are drastically reducing that baseline cancer risk.
Absolutely. But the protocols demand that patients monitor their tissue for sudden, uncharacteristic changes.
What should they look for?
If you have a well-controlled disease that suddenly presents with a new, thickened lump, an ulcer that refuses to heal, persistent bleeding, or an area of redness that completely ignores the steroid,
You don't just increase your dosage. You go straight back to the clinic for a biopsy.
immediately. You must ensure the inflamed cells haven't mutated.
Okay, we have covered a massive amount of pharmacological and practical ground today. Let me try to synthesize the core protocols for you listening.
Sounds good.
If you are navigating clobetasol treatments for mucosal tissues, your success relies on 4 key pillars. First, geographic precision. 1 fingertip unit, half a gram, applied only to the specific lesions. Fight the instinct to smear.
Crucial.
Second, the controlled descent. Follow the strict, multi-month tapering regimen to glide the immune system down, preventing rebound flares while keeping your total dosage safely in the 30 to 60 grams a year range.
Perfect.
Third, environmental control. Respect the 30-minute emollient gap so you don't dilute the drug. Never trap heat and moisture with tight wrapping. And remember how your vascular tissue interacts with liver enzymes. Skip the grapefruit juice.
No grapefruit.
And fourth, vigilant monitoring. Know the difference between a normal sting and a prolonged allergic reaction. Watch for the microbiome shift that causes thrush. And stay alert for internal red flags like profound fatigue or sudden vision changes.
It is a phenomenal amount of responsibility placed squarely on the shoulders of the patient, but adhering to these protocols is the only way to safely wield this remarkable tool.
Definitely.
And it leads me to a final thought I want to leave you with today, one that builds on the underlying biology of these clinical trials.
Let's hear it.
When we use these incredibly potent steroids to fundamentally suppress the immune response at our body's most delicate borders, are we merely managing a persistent disease? Or are we, over years of treatment, permanently changing the localized memory of our immune cells? Could the ultimate key to finally curing these mucosal conditions lie not in developing stronger suppressants, but in figuring out how to fundamentally reprogram the tissue so it simply no longer recognizes itself as the enemy?
Wow. That reframes the whole challenge. Because right now we are still relying on the demolition charge to open the door and hoping we don't bring down the house in the process.
Exactly.
It takes an incredibly steady hand, perfect timing, and absolute focus. Thank you for joining us on this deep dive into the source material. Keep asking questions, keep reading the fine print, and we'll catch you next time.